So I'm going to talk about diabetic foot attack. Uh, so I know most of you all would be familiar with diabetic foot ulcers, right? So we call diabetic foot ulcers. So why call it an attack? Why do you want to change the vocabulary, the name? Does it carry anything, right? So we'll start with that. So what is diabetic foot attack? Diabetic foot attack is acutely inflamed foot with rapid progressive skin and tissue necrosis. So that means there's acute inflammation or infection within the foot. But why call it an attack? So what are the attacks that you have heard of before? See, students, yeah, heart attacks, right? So heart attacks, that's a common thing. So why are you worried about heart attacks? Huh? That is because it could be life-threatening, right? So by giving the word attack to a diabetic foot, it gives a sense of urgency. Shows that as similar to heart attack, a diabetic foot can also kill a person. You understand? So that is why the vocabulary. So why I chose this lecture topic was my registrar was telling me this was novel to him. This was news to him to hear diabetic, not this registrar, the previous one, that he has never heard that diabetic foot called as an attack. But that is the correct nomenclature that gives a sense of emergency, right? So that means when you see a diabetic foot with superadded infection and rapidly progressive tissue necrosis, right? That gives the sense that you need to attend to it immediately, right? So that is the whole the weight it carries. It requires immediate recognition and urgent aggressive management to improve limb and life survival. The concept is time is tissue. Need intervention within hours. You have heard about the golden hour for the cardiac heart attacks. So even for the diabetic foot, there's a time period that you have to attend urgently. You can't postpone it for the next 48 hours after, right? Something like that. The time is tissue. So the prevalence and risk, as you know, the diabetes is the risk of diabetes, the number of diabetic patients are significantly increasing. With every day, we see more and more patients becoming diabetics. In Sri Lanka, roughly 1 in 4 people have diabetes, 23% prevalence in 2023. These stats. And 19 to 34% of people with diabetes will have a diabetic foot ulcer in their lifetime. And 20% of diabetic foot ulcers end up with lower limb amputations. And 63% of these post-amputees die within 5 years. Right? And 40% of diabetic foot ulcers die within 5 years. So that shows this is a killer. Right? Even amputation, in a way, it's like a killer. Right? So that is why we need to try to salvage, identify early and try to do all the measures to salvage. Because sometimes we may have to amputate, but again, amputating means in a diabetic, the mortality is increased, 63% mortality. That means 30 plus survival only in 5 years, right? So diabetic foot attack, it is classified as typical and atypical. Typical is the one we see with abscesses, ulcers, the typical red, hot, swollen foot, where the infection is the main driving cause. There's another category called atypical foot attack, where there's either predominant ischemia, or if you have heard of Charcot's foot. I don't know whether you have heard of Charcot's foot. Students, right? So that means there's arthropathy or neuropathic destruction of the bone, something like that, right? Arthropathy. If it is acute onset, and in that case, that is also considered a foot attack. There's no, the bacterial infection is not the primary cause, but the the arthropathy and ischemia causing tissue necrosis, right? So that is also a type of foot attack which is atypical. The pathophysiology. Now, in diabetes, to have an ulcer or infection or foot attack or whatever, the three main important things. One thing is ischemia, right? They have microangiopathy and macroangiopathy. There are distal vessels, the microvascular circulation also can be affected, as well as the macro. That means the large vessels. They can have peripheral artery disease, no pulses, right? So micro and macro atherosclerosis and all these things can contribute to spontaneous, or with easy trauma, they can get easily ulcers, right? With subtle trauma, they can easily get ulcers, right? So angiopathy. The next thing is the neuropathy, right? So the diabetics can have sensory neuropathy, autonomic neuropathy, and motor neuropathy. So all the nerves are affected. With sensory neuropathy, because they can't feel any pain, any trauma will go unchecked. They won't notice. They would be, even with a subtle trauma to the foot, they will walk on it without realizing that it has got infected, because they can't feel. They don't have pain unless they see, or the doctor sees the foot. They won't know that they are having an infection, right? Because of sensory neuropathy. And motor neuropathy causing all these diabetic foot changes. They can have arch changes, their toes are changed, right? So they are, even with subtle trauma, they are prone to get more ulcers, right? So motor neuropathy, autonomic neuropathy, and sensory neuropathy, all the three factors contribute to ulcer formation. So sometimes it could be a combination of factors. They can have ischemia and neuropathy both. So those are called neuroischemic ulcers, right? And because they are diabetic, they have poor immune response. The immune responses are poor, the infection can spread easily. So the triggering factor would be just a skin, a small skin abrasion. The infection goes in and then cause all the trouble, right? So that's basically the pathophysiology: neuropathy, ischemia, and poor immunity. So diagnosis of a diabetic foot attack, it's always clinical. Like most of the things in our field, it's the detection in the of the initial person, the first person of contact, right? So they can have the typical infective inflammatory features of redness, edema, discharge, foul odor, and they can have typical infective or inflammatory features like warmth and rapidly progressing acute in onset, and systemic features like fever. But they may not also. That is where the problem comes in identifying. They may not have the typical features of infection or inflammation, and you may not detect it unless you look for it specifically, because most of these people have now the second picture, the first picture with the black scab on the foot heel, that was one of my patients whom I have operated on the other side. It was the contralateral leg problem he came with. That wound actually has healed. So my hyper enthusiastic medical officer just looked at his other foot, the sole. The patient didn't know that he had that. My medical officer detected that, right? Because he spent 5 minutes to just get his foot up and see the underneath of the sole. That is how that was detected. That was a foot abscess, right? So that is how it comes. You have to always check the sole of the foot. Otherwise, you will get the foot ulcer missed, or the infection missed. The foot attack is missed unless patient comes with overt, until the patient comes with infection or the systemic sepsis or whatever, right? So this play with. Now, if you look at this foot, you can't see anything, right? It looks almost like a normal foot. You can see little bit of an erythema in between the fourth and fifth toe, right? That almost looks like nothing. but you press. I don't know whether you can appreciate the pus coming out of the surfaces in between. There's nothing for you to observe, right? It looks like just a little erythematous patch in between the toes. But unless you press and see, you won't see the pus underneath, right? That is how it is missed, right? So the message is always when you see a small ulcer, even a small breach of skin, press and see whether you can elicit any discharge from it, right? A similar one here, I don't know whether this will play. It's not playing, but it's a similar example. So yeah, so that is the thing that we may miss. So always inspect the sole of the foot, always press and try to elicit whether there's any discharge, right? So setting that aside, then coming to the topic, they can have the typical features of infection and inflammation as well, local signs and systemic signs, like local swelling, erythema, tenderness, pain. I have discussed this, and they can have super added features of SIRS as well, with hypothermia, tachycardia, hypotension, high white cells count, and so forth. So that means there's ongoing infection causing local and systemic signs. That also could be there. So whenever you see a patient, now you have identified now this patient has infection, you have to, before proceeding with the next step, you have to remember to check the pulse as well, because now we are talking about diabetics who have risk of ischemia. So before putting your scalpel or doing anything else, you have to just check the pulse, make sure there's no macrovascular problems in this patient, right? So pulse assessment is very important. The most, the smallest thing that can be done is just bend down and check the dorsalis pedis and the posterior pulse at least, right? The other pulses may be difficult to feel, but at least if you can feel the dorsalis pedis and posterior and appreciate that it is not present, then that is sufficient to identify that it is ischemic. The other objective assessment anyway would be done by the vascular team, ankle brachial pressure index, ankle pressures, toe pressures, and so on, that we will be doing just to subjectively measure whatever the ischemia that are clinically detected by absent of pulses. Right. Now you have a patient with diabetic foot infection, diabetic foot attack, with or without ischemia, right? With or without neuropathy. Now, all these things are clinically assessed. Then there are different classification systems that are, organized just to, compare. And it's easier to decide on the management when you have a standard guidelines, right? There are so many classification systems like IWGDF, which they would consider more on the infection severity. There are something called Wagner classification, PD's classification, and so on. I'm not going to go detail into these things, but they will assess the severity of the infection. All these classification will give the severity of the infection. The classification we use as vascular surgeon is Y5 classification. So we get the ischemia part also into this infection, this thing. So we assess the wound, ischemia, and foot infection, all three. And our severity assessment is depending on all three, right? How deep the wound is, whether it's a superficial wound, whether the wound has involved the digits, whether the wound has gone beyond the forefoot and midfoot region, something like that, depending on the wound. Then we classify depending on the infection, whether it is just a local infection, whether there's ascending infection, whether there's systemic infection. That is the I. Then FIH, foot infection. And I is for the ischemia that we assess by measuring the toe pressures, right? From this, we get a complete picture of the patient's foot status, right? What Wi-Fi category that it belongs to. And it gives an idea of the urgency of revascularization and the risk of amputation, right? Something like that. Okay, now we have a patient, diabetic foot attack. The basic things are assessed. the investigations that we can do routine bloods to assess the infection status, like full blood count, CRPs and things. The culture and ABSD, usually it should be a deep swab culture, not the superficial swab culture. We prefer the pus culture if you are taking a swab, or we always prefer the tissue. The tissues give more valid results, right? And X-rays if you are suspecting osteomyelitis or Charcot's. So the management. So the management of a patient who comes with diabetic foot attack. Preserve limb function while managing the infection. We want to preserve the limb as much as possible by controlling the infection and do the necessary. Amputation would be the easy way out, but as I told you before, amputating the limb means you are getting the mortality up. The patient is going to die eventually. The 63% die in 5 years, right? So that is why salvaging the limb is important. Salvaging the limb has survival benefit, right? So it's a multidisciplinary approach. It would involve the vascular surgeons, the physicians, the microbiologists, the endocrinologists, orthopedic surgeons, everybody, because all their inputs are important in managing this. So if there is pus or abscess that requires urgent drainage, there's no point of giving antibiotics, keeping a pool of pus inside the foot. The antibiotics won't, heal it when there's a drainable amount of pus. So urgent and that debridement cannot be delayed for the next available list. Cannot be delayed. It should be done the same day, if possible, right? It can't be delayed. So if it is non-ischemic, the aim is to remove all the infected necrotic tissue, exposed tendons, everything. Do a thorough debridement, take everything out, provided the blood flow is good, right? And send the tissues for culture and ABSD. Do a very good debridement. The first debridement is the most important thing, right? If it is non-ischemic, that means the blood flow is good, you remove everything. All the infected, necrotic, exposed tendons, specifically the exposed tendons. Because I don't know whether there are a lot of students, I don't think you have done these wound debridements and all. If there are surgical team people, so the most common culprit of these foot infections are the tendons. So most of these infections spread along the flexor tendon. That is how they go around. So when they are doing the initial debridement, you always have to get the tendon, pull it and cut it short, pull through the wound and cut it. That will prevent the spread of the infection. So we see the requirement of repeated wound debridement when in the initial wound toilet, when these tendons are not taken out. If they are taken out, you don't need repeated wound debridement. You do one good wound toilet in the beginning, and the sole incisions are also put along the flexor tendons. Those are called Loeffler-Ballard incisions. So that is the recommended foot incisions, right, in diabetic feet. So if it is not ischemic, you remove all the infected tissues and do a thorough debridement. But if it is ischemic, now if it is non-ischemic, you get the infection out, right? If it is ischemic, then it's not advised to do a debridement, a full debridement like that. Why? What is the problem of doing a complete debridement in a foot which doesn't have pulse? Lakni? If you are listening to the lecture, you can work it out. Yeah, because when there's no blood flow, how much you cut, it won't bleed. I mean, you will be keep on cutting. What is the extent you are going to cut? Right? when it is not ischemic, that means the blood flow is good. You remove all the necrotic, dead and dying and infected tissues, and you get a good bleeding surface. But if it is ischemic, how much you cut, it's not going to bleed like that, right? So the principle of managing an infected ischemic foot is do a limited debridement just to take the infection out. So you convert an infected ischemic foot into a non-infected ischemic foot, and then we do the revascularization. That is where the vascular surgeons come. We do the revascularization. After revascularization, we do a thorough debridement. Then it heals, right? So that is how it should be done, right? Then the antibiotics. Then all these measures, the wound debridement should be combined with the appropriate antibiotic cover. It should be considering the causative organ, the institution, depends on the institution, bacterial flora, the country and everything. So we start with broad spectrum antibiotics, which would cover negatives, positives, anaerobes, everything. Then we change to the culture specific ones and the glycemic control as well. So the other things that commonly done in practice is most of the time when you see a wound, what you do a swab culture. That is the most common practice in our wards. But the swab culture will not give any significant idea about the infection. The problem is if I do a swab culture from my skin, would it be positive or negative? It would be positive, right? Because all of us have skin flora. So there's no point of doing a swab culture on a wound. If you want to do a culture, that should be, because that will give an idea about the biofilm only. We are not treating with antibiotics. We are not treating the biofilm with antibiotics. There's no point of doing it. If you are doing a culture, it should be a deep swab. If it's a swab, or we always prefer the pus culture. If there's a pus or discharge, we can culture that. Or the tendon or the tissue is much better. When we are doing a wound debridement, we always send the tissues, the tendons or whatever the infect. So that will yield a more proper result. Otherwise, you are just treating a colonization, which would cause the antibiotic resistance. And then when the actual antibiotic is identified, we don't have antibiotics to treat, right? And I'm not going on these antibiotics because I am not the expertise to talk about this. But we usually start with in our practice a beta-lactam antibiotics in the initial mild to moderate. Then we go with the higher broad spectrum ones if it is not settled. So the specific antibiotic according to causative organism, antibiotic sensitivity, clinical severity and efficacy and cost considering everything, right? So the other thing is like the antibiotics, we should always treat it with IV in the initial severe phase, and then once it is settled, we have to change back to oral. Misuse of antibiotics can give rise to drug resistant organisms. Right, so that is about the initial management. Now, diabetic foot attack. If it is a non-ischemic infected wound, we do a thorough debridement, get the wound sepsis out with the adequate antibiotic coverage. If it is an infected ischemic wound, we do a limited debridement, convert it to a non-infected ischemic wound, again in the coverage of antibiotics, right? Now, we have to if it is an ischemic wound, just getting rid of the infection is not going to cure the wound. We have to revascularize it, right? Then we come into the picture, and then we go and assess the patient's arterial tree. We do imaging, arterial duplex scans, CTs if necessary, digital subtraction angios if necessary. We assess where the lesion, what could be done, right? So considering different patient factors and these anatomical factors, we decide either to do an open bypass or an angioplasty, right? We may harvest his or her own vein, do an open bypass like this, or we can put a balloon and dilate the vessel, do an angioplasty. So then you can do a proper debridement after revascularization and continue on wound care until the wound heals. So that is one now. Now, infected ischemic, we revascularize once the infection is out. And there's another arm where the patient can be neuropathic, right? Now, infection is sorted, then you have to sort the neuropathy. Otherwise, wound is not going to heal, right? So the wound healing means you have to act on all these contributing factors. You get the infection out first, right? So you have got the life-saving things done. Then you manage the rest of the things that would require for the wound healing. If it is ischemic, you revascularize. If it is neuropathic, then you have to offload. The principle is offload. Management of a neuropathic ulcer is the principle is the offloading. Medical students, have you heard about that? So I heard about offloading as a third year medical student, right? So I'm teaching you, right? So what is offloading? The word says taking the load out. So how does the neuropathic ulcers happen? Because the patient keeps on walking on the ulcer because they can't feel. Now, when you have a wound on your sole, if you can't, why can't you walk on it? Because you feel pain. You will be either hopping on the foot, right, or do something to prevent the weight bearing on it. But the neuropathic diabetic patient doesn't feel any pain, so he will be nicely walking on the wound. The more he walks, the more tissue damage he is going to get, right? So the offloading is aimed at taking that off out from that ulcer. So there are different ways that you can do it. So the second, the picture that you can see with the gauze and the gauze bandage is what we do in our clinics. When they have an neuropathic ulcer, we dress the ulcer and we put a gauze bandage just underneath. So when he walks, he will be walking on the gauze bandage, not on the ulcer, right? And we advise that is a very cheap one. Now, if we ask them to get a diabetic diabetic footwear, sometimes they may not take it, considering it's 5,000, 6,000, and all sorts of things. This is easier way, and they will they have to work on it because now we have dressed it and plastered it, and they can't remove it, right? So that is what we do in our clinics. The one on the right hand side is how you offload a heel wound. Now, the common practice to offload a heel wound is like take a glove and put some water and put underneath the heel. But is it properly off? Does it do the job? Is it offloading? I mean, there is a surface in contact with the ulcer, right? So that is not the way to offload a heel ulcer. Offloading heel ulcer is putting a pillow underneath the calf. Then the whole heel is out of touch. It's properly offloaded, right? So those are the ways that you can offload. I'm almost at the end of my lecture. And there are different footwear also that you can commercially make. Even the orthotist, you can request the orthotist to make them. There are properly manufactured offloading footwear, right? The other thing, what I don't know whether if one of you medical students remember one day, if you find a patient with a neuropathic ulcer, right? In clinical practice, what I do now, apart from that, like putting that gauze bandage underneath, I ask them to buy 2 pair of barter slippers, right? And one pair, I ask them to remove the straps and paste it onto the other barter slipper, right? So they have two sole thickness barter slippers pair, right? So I asked them to cut a hole where the ulcer is on the touching surface. I don't know, you understand, because that is cheap, they'll do it. And they love barter slippers, right? It's a hi-fi footwear they won't buy. Right. Okay. So that is all about neuropathy. Management of a neuropathic ulcer is offloading, right? Okay. Now these are like if you have osteomyelitis, then you have to get whatever the infected bone out, otherwise it won't heal. If you are suspecting osteomyelitis, something that you can do in the outpatient setup is put a probe and see whether through the wound, whether the probe goes and hit the bone. If the probe to bone test is positive, very likely that there is underlying osteomyelitis. deteriorates, right? Then you can confirm it with the x-rays and see whether all these changes of osteomyelitis is there, and then you can debride the bone and send for culture and see. You don't have to actually do amputations. What we do, we initially do all the bone nibbling and remove all the infected bone, right? And see whether we can salvage. Then Charcot's, it's all about joint stability. In Charcot's, acute Charcot's foot, it's all about maintaining the joint stability. There is no bacterial infection in Charcot's foot. So you have to maintain joint stability. The thing that is used in other countries is the total contact cast, very unpopular among our patients because of the weather and humidity and all. They don't want to keep the cast. So never successful, tried it, never successful. And if the orthopedic colleagues are very enthusiastic, we can refer for a surgical fixation even in Charcot's. There are centers in other countries, they do these, like orthopedic surgeons. Right, so that is all about the diabetic foot management. So you have an infection, you control the infection, do a debridement, take the infection out. If it is an well vascularized foot, it will heal with proper wound care. If it is ischemic, do the revasc. If it is neuropathic, do the offloading. And in that, proper antibiotics and proper glycemic control is achieved. So that is the whole management. And then the next step is the follow up and prevent further infection, further tissue damage. That requires regular foot exams and proper footwear, as I explained. Foot care advices. So 5 foot care advices I give to my patients, that they have to always wear footwear inside and outside house, always, even if they go in this for the religious activities, still that they have to wear at least a sock if they are not happy to wear this thing. And every night before going to sleep, as a habit, inspect the sole of the feet, so they won't miss anything. They themselves can identify if there's any unknown injury. And apply some moisturizing cream or something to prevent cracks and because of the dry skin. Proper nail cutting to prevent the ingrown toenails, the horizontal cutting of the nails. And if there's any subtle injury, they have to seek medical advice and advise them on glycemic control. So in summary, diabetic foot attack is a medical emergency because it can affect the limb as well as it could be life-threatening. Prompt identification is important because it can be easily missed unless you specifically look for it. Urgent debridement should be done to drain pus if there's pus. Should not be delayed for the next available list. And the correct underlying cause like ischemia, joint stability, infection, follow-up and prevention is necessary. Thank you.